Please can you present your clinical findings in this case?
This is Miss Fisher. Miss Fisher has had video-assisted thoracoscopic surgery. The clinical signs are 2 scars on the right lateral chest wall and a smaller, more faded scar on the right side of the back. The rest of her clinical examination, including her breath sounds, was normal.
Tell me about the potential indications for video-assisted thoracoscopic surgery.
Indications for a VATS procedure would include a lobectomy or wedge resection, a decortication, bullectomy or pleurectomy, which may be part of the treatment for recurrent pneumothorax.
Okay, you mentioned a number of differential diagnoses there. Tell me, do you think that this lady has had a lobectomy?
I don't think she's had a lobectomy. The reason for this is that the rest of her chest examination was completely normal, and the indications for lobectomy are often related to smoking-related disease, of which this lady has no clinical signs.
You mentioned surgical management of pneumothoraces there. Tell me, what's the difference between a primary and a secondary spontaneous pneumothorax?
A primary spontaneous pneumothorax is a spontaneous pneumothorax in an otherwise healthy person, whereas a secondary pneumothorax would be associated with underlying lung disease.
You mentioned that this lady's chest examination was otherwise completely normal. So let's presume that she's had a primary spontaneous pneumothorax and has had surgical management of that. Tell me, what's the initial management of a primary spontaneous pneumothorax in a breathless patient?
So, as with all acute medical presentations, this should be managed with an ABCD approach and reasonable and rapid elevation and calling for senior help. In terms of the specific management, in a primary spontaneous pneumothorax, you can initially try to aspirate the pneumothorax up to 2.5 litres. If the patient then stops being breathless and there is evidence of no residual pneumothorax or residual pneumothorax of under 2 centimetres, they may be discharged and followed up as an outpatient. However, if aspiration doesn't relieve the symptoms, or there is a larger residual pneumothorax, then insertion of a chest drain may be required.
Is there any role for suction in the management of a pneumothorax?
Chest drain suction is very rarely used. The reason for this is that it carries a risk of re-expansion pulmonary edema.
Tell me about the surgical management of pneumothoraces themselves. Talk to me about the difference between a VATS approach and an open thoracotomy approach, and any benefits and risks of either option.
In general, for a first spontaneous pneumothorax, surgical intervention would not be indicated. However, in patients who have ongoing problems, including an ongoing air leak, or in patients who have recurrent pneumothoraces, surgical intervention may be an option. In terms of that intervention, pleurodesis or pleurectomy may be the treatment that can be offered. Equally, if there are bullae or blebs, a bullectomy could be offered. The options for surgical management would be between an open thoracotomy and a VATS. A VATS procedure is a much less invasive technique and carries a lower risk of ongoing pain, wound infection, and in general is associated with earlier hospital discharge and return to normal activity. However, after a VATS procedure there is a risk of recurrent pneumothorax, which is greater than the risk of recurrent pneumothorax with an open thoracotomy. The risks are approximately 5% and 1% respectively.
Okay, thank you very much.
Thank you.